Good afternoon, everyone. Thank you for joining today's webinar on diet and child health. My name is Vasudha JV. I'm one of the GP registrars. I'm organizing this webinar series. So this is our 5th webinar in the webinar series, Diet, Nutrition and Health. I'll just go through some housekeeping rules. So please stay muted and turn off your camera during the webinar. And please use the chat function to ask any questions, and we'll get back to your questions at the end of each presentation. And I will answer those questions before moving on to the next presentation. And just to let you know, we are going to record this webinar, and it will be shared on the Healthy Brum YouTube channel to make it available to those who couldn't attend today. Yeah. And this is today's outline of the session. It's really going to be a good session. We have got really good topics and expert speakers for today's session. So Sarah Bates, she's an NHS nutritionist and Startwell team leader. She's going to talk about Startwell program, healthy weaning, and how to deal with fussy eating. And Kathy Lee, our senior program officer, she's going to talk about healthy start vouchers. And Dr. Zainab Mohammed, she's a pediatric endocrinology consultant, and she's going to talk about role of diet in type 2 diabetes in children. So now I'll pass over to Sarah for her presentation. Thank you. Stop sharing.
Thank you. And then I'll share.
Yeah.
Can everyone see that okay? So, yeah. So thank you for that welcome, and thank you for inviting me today. So as has been said, my name is Sarah Bates, and I am an NHS nutritionist. So I work for Birmingham Community Healthcare Trust. And this afternoon, I'm going to give you a very brief overview, because there's not a lot of time to cover 3 topics, but a brief overview of what the Start Well programme is, and the basics around weaning and fussy eating. So, and at the end, I will signpost more information as well if you want any more information about those topics. So first of all, to just explain what Startwell is. So I am the team leader, so I manage the programme, and Startwell is an obesity prevention programme for nurseries and children's centres in Birmingham. So that's commissioned by Birmingham Public Health. And we work with early years settings on food, so healthy eating and physical activity in the setting, to try and make the nursery environment, the children's centre environment, the healthiest it can be, and pass those messages on to the children and also their families and parents at home. And we do a lot of that through the characters that you see on the slide here. So we use cartoon characters with the children and the staff that we've created. And this is because there is evidence base that using cartoon characters really engages children, and it is effective in achieving health behaviour change. If any of you work with young children or have got your own children, you know that they really like characters, things like Peppa Pig or Paw Patrol, and it's just kind of using that in a different way to try and get them to understand around food and physical activity, and repeated exposure over time will lead to those health behaviour changes. So Startwell has 8 key messages that we focus our programme on. Those are: 1 is being a role model, so that the practitioners and parents are acting as a role model to the children, and peers acting as a role model with each other. And then we have 3 food messages and 3 physical activity messages. And we also have our oral health character as well, because that is really important. So some of the food characters we will talk as I go through the presentations talking about weaning and fussy eating, but it was to let you know that this is going on in Birmingham. It is an award that the settings can work towards, and they have to supply evidence of how they're meeting certain criteria and that they've made changes in their setting, and they would be awarded a Start Well award. That would then be valid for 2 years, and we would reassess the setting and make sure that they've kept up those good practices, and then they could be reissued with a new certificate. So first of all, I'm going to cover the very basics of weaning. So one of the most important things is, when do we start? When do we start weaning? It's really important that people understand the signs and what the recommendations are. So the recommendations are to start weaning around 6 months of age. So before that time, the baby doesn't need anything apart from its breast milk or formula milk if it's having formula. It can get everything that it needs from those things. Weaning before this age is linked to developing allergies later in life. And around 6 months, the stores that the baby is born with, they are running low. So it's a reason why that 6 months is a really important time for weaning to start, so that they can get that iron from the foods that they're going to consume. 6 months is also this kind of window of opportunity that you might hear people talk about, where the babies are ready and open to new tastes and textures. So it's a really good time to introduce the food. And once weaning starts at 6 months, it's important that the breastfeeding or the bottle feeding still continues, and that will continue up until 12 months. And as the babies start to eat more solid food, the quantity of milk that they're having will decrease and the food will increase. But to begin with, that milk is still really important to get their nutrients. So we know that the recommendations are 6 months, but we also need to know what signs that our baby will be showing when they're ready to start weaning. And there's a really good website and information that you can get from Start for Life. So it's a kind of a partner of the Change for Life organisation. And they've got this slogan, which I think is really good: no rush to mush. So the guidelines for weaning have been at a younger age previous years, but the evidence base is that 6 months is the time. And all the signs kind of marry up with that. So there are 3 signs that you really want to look out for to know that your baby is ready for weaning. And those 3 signs are here, so that the baby can sit upright and hold its head in a good position. So unsupported, it can sit up and hold its head in a good position. We also want the baby to be able to coordinate their eyes and hand and pick up a food and get it to their mouth. And the third thing that we're looking for is that the baby can swallow food. Babies that aren't quite ready for food will often push it all out rather than actually swallowing the food. So we're looking for those 3 signs to all be happening at the same time. And that typically will happen at around 6 months. There might be other things that are signs that people think that it means that the baby's ready for weaning, but it actually might mean something different. People will often say, oh, well, they're really hungry after their milk feed. They don't seem satisfied. Well, that might just be that they're going through a growth spurt, so that their milk needs to increase. And another thing that we often hear is that, oh, they're really interested in the food that we're eating. They're interested in everything that we're doing. So if that they're hungry after a milk feed and they're interested in food and they're 6 months and these 3 things are happening, then yes, that would be a really good sign that they're ready for weaning. But as if those other things in isolation, then it probably is something else, that they're going through a growth spurt or they're just really interested in what you're doing. So we're looking for those 3 things to happen at the 6 months age, which is a really good sign that we know that they're going to be ready for this next stage. You might have heard this term, baby-led weaning, or kind of traditional weaning. So I'm just going to spend a few minutes talking about the differences. Traditional weaning is where an adult, the parent, the carer, the practitioner is kind of in control of that feeding process. They are mainly spoon feeding the baby a suitable texture of food. Whereas baby-led weaning, which is becoming a lot more popular, is letting the baby feed themselves right from the beginning, right from the very beginning. So they would never put a spoon into the child's mouth. The baby would be left to feed themselves. Often with baby-led weaning, the baby eats the same food as the rest of the family. And with baby-led weaning, the babies are allowed to explore the food a lot more. So they look at the texture, the smell, the taste of it, and then it's up to the baby whether they eat it or not. So the food would be put in front of them, there'd be a lot more sensory exploration, and then the baby would eat or not eat the food. So it might take a little bit longer to begin with to get going, because there's that exploration is really important in baby-led weaning. And often parents using this method will be really worried that they haven't eaten anything, and then they have a dirty nappy a few hours later, and actually you realise that they've eaten a lot more than you thought. Babies can still experience sloppy foods like yogurts with baby-led weaning. So you could preload the spoon and give it to the baby, and then the baby hold the spoon and put the yogurt in their mouth. Or it might be that you have some soft foods like some fruits, and that they're given some finger food to put in their hand, and then they put that food in the yogurt and they eat it off there as well. So they can still experience the kind of the sloppy food as well as more textured food. There isn't necessarily a right or wrong answer. It's what you feel comfortable with doing. I do think baby-led is becoming more popular, not necessarily more popular than traditional, but more popular. And a lot of people will do a combination of the two. They will do lots of finger food and lots of opportunity for the baby to feed themselves, which is more down the baby-led weaning. But there might be some times where they feed with a spoon, which is more like the traditional side. And that is absolutely fine. If you are doing the more traditional style of weaning, then there are textures that you need to be familiar with. So when the baby is 6 months, they're showing those signs that they're ready to wean, and you start weaning them. You're looking for the mashed, lumpy, soft finger food texture. There is no need for them to start on a pureed food at 6 months, because they're that much older. They can manage the food, they can swallow it. They don't need that pureed. So you can go straight onto a mashed, lumpy texture. And we have soft finger foods, things like cooked pasta we've got there, cooked carrots, bananas. The way that you cut the food is really important. I haven't got a lot of time to talk about food safety now, but it's really important that whenever we're feeding, whatever method, that it's always supervised. Using a good sitting position, so like a high chair, is important, and that the food is cut in that long shape so that the baby can hold on to it rather than discs. There's far more risk of choking if it's cut into discs. Moving on to 9 to 12 months, the food needs to be a lumpy texture, and they can have harder finger food. If you were to choose to start before the recommended 6 months of age, so before what the guidelines say, then a pureed consistency would maybe be needed. But it is definitely a consistency. It's not milk, it's not water. Hopefully you can see from that photograph that even though it's smooth, there is some consistency to it. But that would only be needed if you're choosing to wean before the 6 months. If you do choose to wean before the recommendation, we would suggest that you talk to the health visitor, your health visitor, because there are certain foods that you need to avoid. Just because of time, I haven't got time to go into those, so it's important that you get that advice. And I guess as a health professional, because of these guidelines, if we are talking to parents about weaning, we want to get those conversations in early. So maybe around 3 months, to try and make sure that they're not starting early at 4 and that they are waiting to that 6 months. We need to think about, once we know that, what method we're going to use, baby-led or traditional or a combination, and that they're ready to wean and at 6 months, what foods do you need to give them first of all? And these are all foods on this slide that the babies can have. It doesn't need to be boring. Weaning shouldn't be boring. Just the same as if we were being given really bland food or the same food every day, we would get bored. And weaning should be interesting and fun and exciting for the babies. So all these foods they can have from 6 months. And we need to make sure that we are introducing iron-rich foods. As I said at the beginning, those iron stores will be running low. So we want, if you eat meat, so our meat and our fish being introduced, and if not, our pulses and our lentils and our beans, because those are going to contain our iron stores. Touching on our homemade and convenience food. Our homemade would be our preferred option. If we can give homemade food, you know what's going into the food. You can think about the ingredients and the nutrients that you're giving your baby. Hopefully we can be having family meals and getting that role modeling and all that social experience of eating together. And it's also easy to control the quantity and the texture of food that you're giving. Your convenience food, more than a third of the baby meals that are marketed at the under 6 months goes against the 6 months guidelines, and they will say that it's suitable from 4 to 6, and that is a confusing message and something to be aware of. Often parents will think that they have to eat the whole jar as well. They come in quite big jars, so they might end up force feeding the baby because they don't want to waste the money, but also they feel that they need to eat it all, which might not be the case. And there also can be sugar and salt in the baby foods that the children just don't need, especially in the foods that are marketed as finger food snacks. They can contain quite a lot of sugar, so it is something to avoid. So that was a very whistle-stop tour of weaning. To get more information, there is the Start for Life website, which is really good. So I showed that no rush to mush slide that's got it in. And there's also, I've just done a picture here of some of the recipes. There's loads of lovely recipes on that website. So I'll definitely go and take a look. And on the Start Well YouTube page, we also have a short weaning video that you could watch that goes over the basics as well. So moving on to our slightly older children with our fussy eating. This is something that lots of parents say is a problem and get very concerned about. So fussy eaters, or also known as picky, faddy or choosy eaters, are usually defined as children who consume an inadequate variety of foods through food rejection. And fussy eating is actually a normal part of development, and around a third of children at some point may be classed as a fussy eater. So refusing food is often the child's way of asserting themselves and becoming more independent. You know, they're not in control of lots of things. So food can be something they can start to show quite strong preferences over. And although their diet might appear to be restricted, try not to worry, and most children, so almost most of them, will still be getting the sufficient amount of nutrients that they need so that they won't become deficient in anything. But if it is something that you are concerned about, or that you're seeing children who are fussy eaters, I'm just going to spend a few minutes now thinking about the prevention and management of it. And quite often people will go straight to the child when there are lots of other things that could be happening around the child that actually will be really influential and really good to tackle first. So we've got the environment and our role modeling the influence of adults. So it's actually best to work outside in, and the child would be the last thing that you would tackle, because tackling these other things could eliminate lots of the problems. So if you think about the environment, and particularly the mealtime environment, you'll often get parents saying, oh, they eat okay at nursery. Nursery report that they eat fine, but I can't get them to eat at home. And it's thinking about what are the differences in those two environments? Why might that be? So children really like routine, and they like to know what's expected of them. So having a mealtime routine is really important, so that the meals are kind of a similar time every day. The children don't go too long between meals so that they're over hungry, because that can affect their behavior, or overtired. So having kind of 3 main meals and 2 snacks in the day would be the ideal. Often in nurseries, they are sat down at a table, so there's a lovely environment for them to sit in. It's quiet, it's calm, and there is an adult or other children sitting with them to role model, and that's what we want to create. Whereas the pictures on the left is often what will happen at home, where a child might be sat by themselves. They might be watching a tablet or the telly, and they're really distracted. They're not going to be focusing on what they're eating. So the mealtime environment, getting that right, is really important. Then we need to think about, what are we doing? What's the influence of us, their role models? And this can be really strong. So this is where I've put the Susie Startwell character, because this is our role model character in the Startwell program. And the role models that are around the children, their behavior have a big impact. So are they sitting with them and eating? Are they leading by example and showing them that we're eating our fruit and vegetables, we're enjoying them? What is their behavior around mealtime? Are they actually really busy or stressed or distracted, and it's not a nice environment? What's their language around food? Are they saying, oh, I don't want that, I don't like it, well, that doesn't look very nice? Or are they encouraging and they're leading by example? Also, the expectations of parents and practitioners sometimes aren't realistic, and children have really small stomachs, much smaller than adults, and we need to make sure that we're giving them me-size meals. Mickey Me-size is one of the other characters that's part of the program, the Start Well program, and quite often parents haven't realised how small the portion needs to be, and they're trying to force the food on them, or they're putting a really big plate of food down, and that just puts the child off right from the beginning. So a good way to think about if we're giving the right portion size is think about the plate that you're using, because you will often fill a plate. As adults, we often fill the plate. And if you stretch your hand out and draw a circle round the hand, kind of to the bony bits, the circle that you're left with should be the middle of the plate. So it's important to check that your 3-year-old, your 2-year-old, your 4-year-old has the right size plate, and that you're not actually giving them too much food. And making sure that your different age children, so an 8-year-old needs a different size portion to a 4-year-old. They've got different size stomachs and have different growth needs. Then lastly, if you've addressed all those things and it hasn't solved the problem, it's then thinking about the child, working with the child. And repeated exposure is really important. It can take anywhere up to 10 to 15 times of a child trying a food to know that they like it. So it's not to give up if they've rejected it. And they might like it in a different way. You can have cooked carrot, you can have raw carrot. A child might like it one way, and that's okay. They're still getting the nutrients from it. And this repeated exposure doesn't always have to be activities where, or it doesn't always have to be where they're eating the food. It could be activities with food. So we've got the picture on the right of apple prints being used. So the children are getting used to the food, they're getting used to what it feels like, the smell of it, the look of it. So food-based activities, including messy play. So where the end outcome isn't that they have to taste it, is really good experience for them. Involving the children in shopping and food preparation is really good, getting them interested in it, making it fun. And then if you've got some more challenging fussy eaters, desensitization would be a method that we would use. So that would be introducing a food slowly. So it might be only present on the table, then it might make it to the plate the next time, then the next time after that, maybe they could hold it, lick it, and eventually taste it, and it end up being consumed. A lot of parents will say that their children are fussy around fruit and vegetables in particular, and that's something that they want to increase their consumption of. And this again links to one of our characters, Faye, 5 a day in Start Well. And it's kind of building what I've just said about making it a fun experience. So we've got kind of some pictures here of some different activities. If you're having a snack around fruit and veg, you can make it into a nice picture. The children can do that themselves. Cutting up fruit and vegetables is always really helpful. Rather than giving them a whole apple, cut it up. It just doesn't seem as daunting. Food growing is really good and a great activity to do with the children. I'm conscious that I'm near the end of my time. So for more information on fussy eating, you can go to the Start Well YouTube page, and there are 3 videos around fussy eating that you could look at that go into the environment, the influence of adults and the child in more detail. And we also have our Start Well website that has got a lot of information. So there's information for professionals and also for parents on here. And it's got activity ideas that you could use. It's also got information about all the characters, and it's got links to our social media. So we've got Facebook, Pinterest, Twitter, and our YouTube page. So you can go there for more ideas. So I don't know if we've probably got 1 minute if anyone wants to ask any questions. I'm happy to try and answer them. Oh, we can't hear.
Sorry. Thank you, Sarah. It was really good presentation. Really enjoyed it.
Thank you. No, I had to go through quickly.
Any questions at all? Just give 1 minute. Any questions at all? Yeah, I got 1 question. Any side effects of doing weaning late?
Yeah, it can cause problems. So I mentioned that window of opportunity. And if weaning is delayed, then especially depending on how delayed, babies are less open to trying the different tastes and textures. And often you will find that babies get stuck on a kind of mushy texture. Also, their iron stores will be running low, so they could become deficient. So starting that weaning process at 6 months is really key, and that's why the evidence is there and the recommendation for 6 months.
So one more question. Do you cover the Sandwell Borough at all?
We don't. It is only Birmingham, but all the information on our website and social media is open to anyone, so you can still access all that information there, so you can get lots from the programme even though you're outside Birmingham.
Based on your experience, what is the most effective way to deal with when children only eat 1 or 2 types of vegetables and don't even want to try new types of vegetables?
Perseverance, I guess, not to give up. It's great that they are having 1 to 2 types because they'll be getting those nutrients. So keep going with those 1 to 2 types. And then it will be trying that repeated exposure, preparing them in different ways, cooking them in different ways, and lots of activities that don't actually involve eating to take the pressure away. But also think about the whole environment. Is it actually becoming really stressful because we're really trying them to eat this food and the enjoyment has gone out of it? So if they're eating 1 to 2 vegetables, that's great. So don't stress too much. And then keep persevering with others. Try and get other adults or children or siblings to eat them in front of the child as well.
Does weaning age change for premature babies?
It does depend on how prem the babies are. So the age might be corrected depending on when their due date was, but that they would be advised and helped with that with their health visitor. So it just depends how prem they are or if there are any other complications.
Do you have any advice for fuzzy eating for children who are on the spectrum?
So it would depend what condition the child had been diagnosed with and kind of how severe it is. And sometimes it's not worrying so much about what the food is, but just that experience of eating what they are happy to eat. Lots of messy food play where, again, the end result isn't that they have to eat it. So there isn't that pressure to actually consume the food, but they're getting to play and experience the senses. And then as part of that messy play, if they're happy to try and taste the food, that's great. So it's more about maybe not being too hung up on what they're eating, but to encourage that eating. But that is trickier, definitely.
Would giving chicken meat be good for giving nutrients?
So chicken meat has got your iron in it and your protein, so that's really good. The children need it. Just thinking about stock there, I guess that's maybe homemade stock, but stock we need to be careful of because it contains salt, and that isn't something that we want babies to be having lots of. So we try and say not to use kind of your bought stock, your OXO, that type of thing, and not to add salt to the cooking.
Okay, good. Yeah. Mother's milk better than cow's milk?
So the recommendation is for babies up until the 12 months to have your breast milk or formula milk. And then once they're over 12 months, the baby can move on to a full fat cow's milk. If you're breastfeeding, you can continue past 12 months. That's the parent's choice. But up until 12 months, it would be your breast milk or your formula milk. And then once they're 12 months, they can have your full fat cow's milk.
So somebody's written homemade stock with no added salt.
So I think they were just clarifying that. So yeah, that's
fine. All right, that's it then. So we'll pass over to Kathy now for her presentation. Thank you, Sarah.
Thank you.
Hi, can everybody see my screen? Yeah. Excellent. My name's Kathy Lee. I'm Senior Officer in Public Health, and I work in the Children and Young People's team. I'm going to do a presentation on Healthy Start, the Healthy Start scheme. But before I do that, I thought I'd just put a little context into the scale of the problem. Birmingham has a population of 1.1 million. And as you can see, it's a very deprived city with 56% of our residents living in the most deprived areas in England. And it's a young city with 46% of our residents aged under 30 years old. We produce a lot of babies. over 17,000 babies per year, and we have lots of young families. So the healthy start is very important for Birmingham. When we look at child health, one of the key measures is childhood obesity. And we use the National Child Measurement Programme to help measure this. Excuse me. This is the National Child Measurement data for 2018-19. And it shows children who are obese. And this is not children who are overweight, this is children who are obese. And as we can see, the deprivation exacerbates the level of obesity. Now, on the left here, we have children in England in the reception class, so that's age between 4 and 5. And deprived children are more likely to be obese. And as I said before, Birmingham, we know, is a very deprived city. So by the time they get to year 6, children will get to year 6, the gap is widening. There is a slight gender and ethnicity sort of imbalance, but that's not so clear. So I've not mentioned that in this presentation. So Healthy Start Scheme, I'm sure many of you know about the Healthy Start Scheme. And so it's aimed to reduce child poverty and health inequalities by providing free vitamins, nutritional advice, and weekly vouchers to buy food, infant formula milk to low income families with pregnant women and children up to the age of 4. The food vouchers can be spent on fruit or vegetables. Now that can be fresh, frozen, tinned. It can also be used for cow's milk and first stage formula milk. It can't be used for follow-on milk. We also have free vitamins, and Birmingham has a universal offer. So that means all pregnant women and all families have the facility to obtain free vitamins. In April this year, the voucher value increased from £3.10 to £4.20. Now, unfortunately, in Birmingham, there is an underclaim. Now, in 2018, we had the value of £2.6 million unclaimed vouchers, and that has risen now in December to 3.6 million. And we predict that the pandemic potentially will exacerbate that, so if more families will become eligible. So this means that thousands of pounds each week worth of free food is not reaching children who need it. Just to give you a sort of a little bit of context on that as well, the February data, which is the latest data that we only had 61% uptake of Healthy Start vouchers in Birmingham. So that means that that's approximately 7,631 families who are missing out on free food, and that equates to about £64,000. So what are we doing to try and increase the registration? Well, what we're trying to do is to work, well, we have been working with frontline agencies, health visitors, midwives, early years services, voluntary sector, DEP agencies, and the DWP. We're working to just make frontline agencies aware of the changes that are happening with the Healthy Start. One of the changes is it's becoming digital in October. So we're moving away from the paper vouchers and we're going to a card system, very similar to a credit card, and it's going to be used in exactly the same way. This is going to be a staged approach, and it's going to be rolled out, as I say, from October, and we're anticipating Birmingham will be one of the first cities to be involved in that. So there will be a transition period of families moving from the paper version to the card system. I'm happy to give more details about that process to any sort of individual organisation. So if you want me to come and explain to your teams, come to your network meetings, team meetings, I'm more than happy to go into some of the finer details of that and how that may affect you. And that's what I've been doing at the moment, sort of trying to reach as many agencies as I can. What we've also been doing is making it part of every contact. So we've made a big effort to incorporate Healthy Start into existing support packages. We want to increase awareness, not only of the Healthy Start, but also of the changes to the Healthy Start. Because one of the changes that some health professionals may not be aware of, that there is no longer a need for a signature at registration. So that's been abandoned now. But what we are doing is we are having a big citywide promotional campaign in August. We had intended this to be in March, but there's some new national branding which has just come out. So we wanted to wait for that. Hence why now this promotional campaign will be in August. And what we will be doing, we'll be providing each organisation a pack, a resource pack. So that will include posters, that will include leaflets, that will include strap lines for your social media, some graphics, and also a list of local services, support services as well. So if anybody thinks that we may not be aware of you, let me know, email me so that you can be added to our contact list. The other thing that we've done is we've simplified the distribution process. So we've moved it from paper to an electronic system. Now, this has helped us in our collection of data because we do feel that the data has been underestimated, and hopefully this electronic system will give us a more robust data collection system. So the next steps that we're going to take is we need to do more to reach families, and we want to make sure that anyone working with families of young children discuss Healthy Start vouchers and help people to register and claim the vouchers. What we're also doing is we're currently having an open conversation with the government. What we want to do is we're working with DWP to see if we can automatically register eligible citizens whilst they're also registering for other benefits. So that's in the pipeline. We're having those discussions at the moment. And something that's happened this week is to raise awareness of the updated eligibility of Healthy Start for migrant families. There was a legal challenge a little while ago about a mother and child living with no recourse to public funds. And the court ruled that excluding families with no recourse to public funds was unlawful, and it breaches the duty of safeguard of child welfare. So in essence, what that means is that children previously who were not eligible for the scheme due to their parents' immigration status will now be entitled to Healthy Start. Now, the process, as I say, this has only been announced this week. So I'm currently waiting to find what the process is in claiming, because the current application form wouldn't allow that to happen. So again, that is something I want to update frontline staff with, is the process. There's also going to be a review in the winter about the scheme, and so there may even be more changes as the year goes on. So that was a very quick presentation, and I'm open to any questions.
Thank you, Sarah. You have got questions actually. So just read through it. So somebody has written, from experience, health HSV is not easy to claim. Midwives didn't inform, and there was confusion of who could claim, that is not just unemployed. Anti-stigma, is it the same? Yeah, anti-stigma campaigns in local businesses would be useful too.
Yeah, I mean, absolutely. I think there has been a bit of confusion with the registration process, and that's part of the information, and that's part of raising the awareness of how to claim, who can claim. And as I say, if anybody needs more information about that, I can go into a lot more depth about, for frontline staff, on the eligibility of individuals. The other reason why we want to increase the uptake, because that will also help local businesses, because food vouchers can only be used locally, so they can't be used online. So that's going, certainly at this time, that's going to help local businesses as well.
Okay, thank you. So the next question is, do you come to universities to talk to student midwives, or do you have a film explaining all of this we could use with them as part of module?
Yeah, I've certainly got, we recently presented a webinar, but I'm happy to put something bespoke to a university. Again, just contact me, and I can certainly put a video together for you as part of the module. Absolutely. Good. That's a very good idea. Thank you.
The next question is the work you're doing with DWP just for Birmingham or England more widely?
It's just Birmingham at the moment. As I say, we're just in the initial talks, so we just need to sort of iron out a few of the difficulties that may arise. So it's in its infancy at the moment.
Thank you so much, Kathy.
Okay, no problem.
Now we will pass over to Zainab, Dr. Zainab Mohammed, for her talk. Thank you.
Thank you so much for inviting me, Vasudha, and thank you so much, Sarah and Kathy, for a good head start with what you do at a primary care level is great. Thank you. So I'm just a brief introduction to myself. I'm one of the consultant endocrinologists working at Birmingham Children's Hospital. And my interests are, one of my interests is diabetes as well. So I'm going to give a little bit of a talk from a medical aspect of care, what we see with the trend of diabetes in children, particularly with focus to type 2. I'm hoping you all can hear me loud and clear. I'm in the hospital, so can't be trusted with the network. Okay, thank you. So I can see the nod, so I take that as a yes. So just as a summary slide, I wanted to tell you the content of the talk. Just wanted to highlight what is type 2 diabetes in children and how it's different from type 1 diabetes, which most of you are familiar with. How common type 2 diabetes in children is not well understood. And it's important to highlight that for public health awareness. And it's also important to know if children with type 2 diabetes get complications, what are the treatment options, what are the challenges to the treatment options, and the possible solutions as a forward thinking. So to start with, type 2 diabetes is usually associated with overweight when compared to natural healthy weight for children. But not all children who are overweight, that is, a BMI index over the 95th centile on the growth chart, do develop diabetes. There is a select group of patients who develop diabetes, and there is more reasons, with multifactorial reasons for them to develop type 2 diabetes, which can be genetic predisposition to ethnicity, to living and lifestyle changes. Type 2 diabetes in children it's important to know that it is actually very much more aggressive form than those that we see in adults. So it is quite important from public health perspective. Obesity is defined in children as a BMI index over and about 23, whereas in adults it's over 25. And I know that the scales are different for adults, but in children, anything over the 95th centile on the the WHO growth chart is caused as overweight and obese. So it's important to be mindful about keeping a track on the weight in the community, which National Health Data Program does aim to at school level, and also make sure we keep a check on children. Now just delineating the differences between type 1 and type 2. In type 1, in simplistic form, there is an absolute failure of the beta cells to produce the most important hormone which keeps a check of your blood sugar levels, called the insulin. And the pancreas, the important organ that produces, fails to produce. The insulin production factory is completely shut down over a period of time. And that's type 1 diabetes. It's unrecoverable, and we can't treat it in any other form other than giving insulin. It cannot be prevented. It occurs mainly due to an autoimmune phenomenon where the body's own cells are treated as foreign and all the insulin producing cells are damaged. Whereas in type 2 diabetes, usually diagnosed in adulthood, but more recently so much in younger people as well, insulin is produced but not very effectively. It's usually caused by excessive weight gain, and possible genetic factors may also have a bearing towards the lifestyle and predisposition to type 2. The mainstay of treatment in type 2, and you can actually get a cure from type 2 if you maintain a healthy diet and lifestyle, is to look forward towards lifestyle changes and maintaining healthy weight. All those details that Sarah has detailed in her talk. So recapping the public health profile from 2016, we know that Birmingham has one of the most deprived areas in the countries. And overall, we fall in the bottom 20% of deprivation statistics data. We have about 40% of the population living in the most deprived levels in the country, out of which 10% is severely deprived, colored in dark shaded blue on the screen. What we see now is about 30% of these families come from low income groups, and we have an infant mortality rate, one of the highest in the country, which is 7.2 per thousand live births. And 33% of the children are overweight or obese, which calls for a monthly diabetes type 2 clinic, which is run as a service within our hospital. There's other services around Heartland as well in Birmingham community. What we have seen now is an unrelenting march of diabetes across the world. When we look at the comparison between historic data in 1980 to 2014, you can see the comparative rise, whether in America or Europe, a Middle Eastern region, or in the Asian population. There is almost twofold rise in the percentage of diabetes per 100,000 million population around the world. So we can see for the European region, it is a jump from 1980 data of 5.3% to 7.3% of the population developing that. And this is more worrying when it comes to children. We now know that amongst all cases of diabetes that we have diagnosed, as per the NPDA data from 2018, 2.5% of all young children have type 2, which is a worrying number, and it is only on the rise. Although most of the diabetes is mainly related to type 1 in children, we are now seeing a growing exponential number of type 2 diabetes expanding over the world. There are other non-type 1 related diabetes which are not a part of this, which are listed. And which is why it brings our attention more towards the population surge and the reasons for adapting healthy lifestyle changes and providing public awareness with regards to prevalence within the population. Now, bringing your attention to 3 or 4 main important facts compared to the data from 2006 to 2016. What we know within the white Caucasian population, we have a rise or an increment of type 2 diabetes from 0.35 per thousand per year to 0.44. That is almost about 40% rise over a decade. And if you compare that data to a South Asian statistics, it's almost 120% rise between 2006 to 2016. And that's a worry, big worry. We are seeing this data about 57% in girls and 67% in females when compared to the 2-year. And ethnic minorities seems to have 43% higher chances of developing this. More so, about 80% of them who are obese or in a higher or overweight category, or those with acanthosis nigricans. These are dark marks of insulin resistance around the neck and the armpits that you can find, which is called acanthosis nigricans. And they develop, about 50% of them presenting with that develop type 2 diabetes. And those with family history of diabetes or those without any symptoms at presentation can also present with diabetes related to obesity, as published in Lancet data. So why do people get type 2? This is not a single particular reason. There is a multifactorial reason, and also it seems to be more prevalent in certain ethnic communities than the Caucasian crowd. But obesity and overweight brings a big drive for higher levels of insulin and higher glucose, which can cause our body to not respond to the insulin and causing a higher risk of diabetes. There are 2 main reasons why you get type 2 diabetes. Firstly, what we call as impaired insulin production. And this is the little cartoon of the pancreas, the insulin which keeps the blood sugars under control. The insulin production itself is impaired in its production. The second reason is the resistance, that the body is so disfigured, or actually the insulin, which works as a key, is not able to work because of the resistance the body shows to insulin. So there are 2 main reasons why you can have diabetes in type 2 in comparison to type 1, where there's complete lack of production of insulin, which is a completely different story. The symptoms, I normally say to families and parents that there are 4 T's in type 1, that is tiredness, thinness, thirst, and excessive toileting. So in type 2, one of the things that will not be a presenting feature is thinness. You are actually excessively overweight, causing a body to be resistant to insulin, which predisposes to type 2 diabetes. That's the only other symptom which is different. And what else can we see? We can see areas of dark pigmentation in the body, particularly around the nape of the neck and the armpits and the groin area, called acanthosis nigricans, or rubbery black skin, which is a sign of insulin resistance. Sometimes you may not see any symptoms at all when we come across type 2 diabetes. But when it comes to complications, the rapidity at which you drive into complications with suboptimal control of type 2 diabetes is much faster when compared to adults. When we look at the data from EPINS published in Diabetes Care, we see that in comparison to type 1, and the type 2 has got almost a fold increase in the level of complications, which include kidney, heart, cholesterol, and peripheral nerves being affected. And it may also matter how long the diabetes has been, and as opposed to 6.8 years to take to those complications with poor control, it only takes about 1.3 years to reach to those complications if we have suboptimal or poor control. And the data represents the same. Complication-free survival is much more dramatically reduced in type 2 and compared to type 1, shaded in dashed shadows here. So it's important to drive a change. Just having health professionals advocate treatment is not going to work. We need to drive a change with the way people think and people adapt to the way they would like to change with their health and healthy eating and lifestyle. When we interviewed the views of adolescents regarding treatment, it appeared that at diagnosis, most teenagers struggle to maintain lifestyle changes. And although they started on medications for type 2 diabetes, it was less effective because of lack of motivation to stick and adhere to maintaining lifestyle changes. Moreover, insulin or adjunct therapy for those who have got impaired glucose tolerance is thought to be less favorable. Some are not surprised that they are diagnosed and they do not realize the implications or the long-term complications that are yet to come, because what the eyes do not see, the mind does not read. So it's important to encourage family therapy when we are dealing with type 2 diabetes, when driving changes, particularly with lifestyle intervention changes, to make it more effective. So the management has got 5 pillars, that is healthy eating, physical activity, in adjunct with medical therapy, and sometimes when all fails, bariatric surgeries like surgical therapy, and most importantly, psychological support. And in order to achieve optimum health, we must respect 3 billion years of evolution and move away from processed food to healthy green stuff, which is going to be the next answer to this epidemic. So historical dietary management is pick something from the black portions of food and vegetables and pick something from the red portions as described in 1963. We then brought about changes to what we can swap in terms of food, from carbohydrate to protein or complex carbohydrate meals and fruits. And then we have got a healthy eating, health and well-being diet, loads of resources available in the community and GP world, where the diet can be based on more of fiber, less of carbs and more of protein. And now we come to talking about food with high glycemic index and moderate glycemic index and low glycemic index. And what we need to know is you have to try and control the amount of carbohydrate, the type of carbohydrate that you eat in an everyday, day-to-day routine practice. And to give you a short example about the high glycemic index, medium GI, and the high fat protein absorbed diet, is that those with a high glycemic index are absorbed within 30 minutes and it leaves the system, such as giving an energy drink like Lucozade or sweet tablets. Those with medium GIs are absorbed within 2 to 4 hours, such as breakfast cereal, sandwich, fruit, mashed potatoes that we use in most meals. But those with high fat and protein, which stays longer and produces your glycemic control to be going up and stays higher for a longer time, such as heavy fat content food like pizza, creamy pasta, fish and chips, Chinese takeaway, and fast food. These are the ones to avoid. So the treatment options, as we heard from the earlier talks, is to maintain a healthy, active lifestyle and use all the resources we have in the community to maintain that glucose level so that we can prevent the long-term future complications with better Eat Well guide and healthy activities and exercise. What do they do to our body? It improves the hormone profile in our body, the way our body metabolizes the food, and a healthy balanced diet will help us keep the weight under control, reverse the insulin resistance. Insulin can be read by the body better and our blood sugars can be controlled well within target. So in adjunct to medical therapy, the first medical therapy we use is metformin. It reduces the release of sugar from the liver and keeps the blood sugar maintained under control. It can cause tummy upset and it's sometimes started at a slower dose to alleviate some of the side effects. But the other oral hypoglycemics have the side effects of getting a lows. So we have to make sure they maintain and check the blood sugars regularly to prevent that. And the injectable ones, which is GLP-1 agonist inhibitors and SGLT2 inhibitors and insulin, are less favorable, but may be required if the control is suboptimal. We have a very clear guidelines of the International Pediatric Society guidelines as to how we manage type 2 diabetes, which is followed worldwide in most centers, including ours. We have an adapted version of the ISPAD guidelines for managing diabetes. And the long term, how we keep a control and a check is to check some marker called the HbA1c. It's like a glucose reader in your blood, red blood cells, which gives you an average control for the lifespan of the red cells. We need to keep the HbA1c within target, within 5.5% for it to be under control, but also keeping your levels in control, the time in target blood sugar, and maintaining a healthy height and a weight would be a healthy weight for height would be the most important thing to ensure that you remain healthy. What's the role of bariatric surgeries for those who have tried all these adjunct activities and we still have an exponential weight gain, and the body mass index, which is weight in kgs divided by height in meter square. If it crosses over 40, we are looking at quite an obese population, and we are heading towards all those complications listed for heart, eye, kidneys, and nerves. So in order to prevent that, which can be at risk for mortality as well, we really need to put actions in place. And bariatric surgeries like gastric sleeve operations are one of the last remedial options to consider when all other adjuncts have failed. It is also important to consider at a lower BMI for South Asian ethnic populations who have got higher incidence of diabetes. But one of the things that we've come across with bariatric surgeries that we lack long-term data about its efficacy. Mortality rate is higher in adults that we know. It can lead on to nutritional or vitamin deficiencies because you are actually reducing the capacity of the stomach, and it can lead on to bacterial overgrowth in the intestine. It can cause something like a dump effect of the blood sugar, and there is ethical dilemmas regarding decisions for young persons. There's also a high risk of suicide and psychological ailment for children who undergo bariatric surgery, and usually they are at a weight of 140, 150 plus kilograms at the start, with a bit of a motivational interviews taken. So we do need alternative solutions. We would welcome the idea of increased intervention from government to drive this change, which is an obesogenic environment. For a short extra 50p, you can go from medium to go large in McDonald's, and that just exponentially expands the way people adapt to what eating lifestyles they choose to. So what we need is to have a specific targeted obesity clinics, which is lacking in both the tertiary centers like ours or externally in the GP service. There is a national drive and recognition more and more and now about the obesity service being needed. We have something called the CREW clinics, or complications related to excess weight clinics, which is being coming as an emerging service across UK. And this is a drive from clinical leads and commissioning leads who are actually looking at piloting these integrated projects. And about 340 million pounds is 340k is being allocated to set up these services across the country. And for East and West Midlands, there would be 2 centers for children and young peoples as a test sites. These will be looking at avoiding complications for children, and there will be opportunity to refer into the service for those with overweight and complications related to obesity, particularly for children. And this will also lead on to bariatric surgery centers and more input into money being poured into bariatric service across UK. So just to conclude, that type 2 diabetes is increasing with the increasing epidemic of obesity worldwide. We now know that the affected children have more aggressive form of the disease and develop complication far quicker than adults. To limit the progression, we really need to know what is the HbA1c. We can predict the progression would be faster if we did know that their average blood sugar at a diagnosis is high. Complications develop earlier, and so treatment options should explore not just medical therapy, but all the facilities in the community, including the crew clinic and psychology input. And most importantly, obesity prevention program or the crew clinics are emerging food for thought. We will need cooperation from families to have these lifestyle intervention embedded with the support from the community. And we hope to recruit to studies to generate efficacy evidence for newer models of treatment that can be developed in diabetes. Thank you for listening.
Thank you, Zainab. That was really good talk, very informative. Any questions? I'll just wait for a few minutes for any questions. What is CREO?
Complications related to excess weight in children. It's a soft way of expressing obesity clinic, but obesity is thought as a stigmata. So NHSE England have used the terminology in a more softer way as crew clinics, complications related to excess weight in children. This will be the new terminology of crew clinics opening up across the country, up and down the country.
Thank you. Looks like that's it. Any more questions? We'll give one more minute. That's it, I think. Thank you, Sarah. Thank you, Kathy. And thank you, Zainab. It was really good session. Thanks. So the next session is on food and reproductive health, which is on next Friday, 2 to 3 p.m., similar time. And we have got consultant reproductive medicine talking about food and reproductive health, and community dietitian who is going to talk about diet in pregnancy. Thank you. You can register now on the Eventbrite for the next session. Thank you, everyone. Thanks. Bye.